this week on the BackTable podcast.
My career has been about breaking down boundaries between specialties. I think where spine interventionalists coming from a radiology background have a tremendous advantage is in the interpretation of the images and the execution of treatments safely because of their comfort with image guidance. It's the appreciation of the importance of the imaging, understanding the imaging, being able to educate our colleagues on the imaging findings, and then using really precise imaging to allow us to do the therapies. I see the emergence of the spine interventionalist, and then that'll involve people coming from different specialties. From my point of view, radiology has a ton to contribute, and I don't think radiology threatens other groups, nor should other groups feel threatened as we work together to advance therapy in tens of millions of patients in the United States.
Hello, everyone, and welcome to the BackTable MSK podcast, your source for all things musculoskeletal. You can find all previous episodes of our show on Spotify, Apple Podcasts, and on BackTable.com. First, a brief message from our sponsor. Stryker's interventional spine business offers the control you need, the flexibility you want, and the quality your patients deserve. Stryker is your partner in making healthcare better. From technology to training, from reimbursement tools to patient education, Stryker is there to support you every step of the way. Innovation is the driving force at Stryker. Their extensive product portfolio for vertebral augmentation and radiofrequency ablation procedures ensures that you have the tools needed to provide top-notch care. But their commitment to advancement doesn't stop there. With recent additions like the OptiBlate bone tumor ablation system and FDA 510(k) clearance for the spine jack system for compression fractures that result from malignant lesions, myeloma, or osteolytic metastasis, you'll be eager to explore all the solutions Stryker has to offer. Learn more at www.strykerivs.com. Now, back to the show. Hello, everyone. Welcome back to another edition of our special ESNR Interventional Spine Hands-On Course podcast. This is your host, Jacob Fleming, and today I'm thrilled to be joined by interventional neuroradiologist Joshua Hirsch from Massachusetts General Hospital. Dr. Hirsch, thank you so much for your time and agreeing to talk to us about some of the excellent topics that the conference attendees will get to be exposed to.
Well, Jacob, it's my pleasure, and let me just thank you for 1 second. I think you've really helped bring spine to the forefront with many of these efforts that you've done through podcasts and other technologies that are outside of my scope. I'm able to imagine participating, but not leading them the way you have. And I really salute you. I think it's been great for the field. And I'm just delighted to be with you today.
Well, thank you so much. That's very kind of you to say, Dr. Hirsch. And I'm equally thrilled to be a part of this course as well. And today we're going to talk a little bit about some of the intradiscal therapies that the attendees can hope to be educated on and also have hands-on experience with at this course. This is a topic that's near and dear to my heart. And you have also been a tremendous advocate for percutaneous discal treatments for a long time. So I'm more of a novice to this area, but I've been very impressed during my training at the prevalence of painful disc disease, but also seemingly its paradoxical neglect as a target of treatment. So my first question to you, Dr. Hirsch, is why do you think the disc has been so historically ignored compared to some of the other pain generators?
Yeah, so I think part of the challenge comes from the diagnostic complexity. So let's take it from a few different perspectives. If you start with disc herniation and or other things causing anatomic rationale for a neurogenic or radicular problem, that's very easy to understand. The disc is in and of itself not really acting as the pain generator, but rather it's pushing on something with or without other things. For years, we talked about discography as a way of diagnosing. And I think the problem is there is such a sordid history to discography, some justified, some not really justified, including the idea that sticking a needle in the disc leads to degeneration, that while we've done systematic reviews of the level of evidence for discography, from the podium, Mike Modick made fun of me for doing that, meaning the reputation of discography is really quite varied. I think that said, that led to various surgeries and things being done for presumed discogenic pain that really never had the chance of working as well as pain for radicular circumstances. And so when the diagnosis is confusing, the treatment is probably less effective than similar counterparts or ostensibly similar counterparts. That could lead to a level of disregard. In my particular case, I originally got interested in spine because of augmentation and was an early adopter, relatively speaking, amongst that cohort of practitioners of percutaneous discectomy. And what I would say is I wasn't an early adopter in that APLD, chemonucleolysis, other things had been around, but amongst my cohort of friends who were really focused on augmentation, I was doing percutaneous discectomy, which led to a lot of academic interest in that area. What I would say is, flash forward, I'm embarrassed to say, Jacob, I won't compare this to when you were born, but flash forward like 25 years from that point to where we are now. And what I could say is the relatively primitive percutaneous discectomy that I was doing, diminishing the pressure on the disc, is being replaced by lots of options that I think over the next decade are going to really declare themselves in this space. So I like your optimism, and don't be worried about being a novice. You're going to have a lot more things in your armamentarium than I had over the last, let's say, 20 years, over your next 20 years. So I think you're coming at a really, really good time.
I absolutely agree, and thank you for those words of encouragement. And that gets to another thing I wanted to talk about is how you've kind of seen these techniques evolve over time. And I agree wholeheartedly with what you said about the evolution over the next decade. And in fact, our mutual friend, Doug Beal, has said that we are now moving into the decade of the anterior column. And I think it's a great time to be a spinal interventional radiologist, very exciting time for emerging therapies and for us to bring both our imaging skills and image-guided interventional skills to bear on this topic. So you referred to some of the evolving treatments that have become available more recently. And can you give us a bit of an overview of the percutaneous discal treatments on the scene or that are coming down the pipeline?
Well, let me just say that disagreeing with Doug Beal is a great pleasure for me. But I can't really disagree except to say that is any decade not the decade of the anterior column? So with that, and for those that don't know, Jacob is spending time with Dr. Beal, and he'll only have to forget about 80% of what he learns when he's finished. I say that because I'm brave when Doug isn't standing next to me. But when he's next to me, I'm much more careful. With that said, what I would say is really exciting about this is the evolution from mechanical depressurization therapy like percutaneous discectomy, which, just to be clear, really has a place, whether it was the decompressor or nucleoplasty, each with its own theory of the case, or more classically APLD, where actually neuroradiologists had a very large role in that procedure where tens of thousands of cases were done. APLD potentially taking out a significant volume versus, let's say, some of the other treatments where you really think about taking out a fairly minimalistic volume but changing the pressure. That's great and exciting, but not really where I think we can go, which is thinking about putting things into the disc that actually help regenerate them, rehydrate them. So I published on something called DiscoGel, which is a novel substance being used in Europe. Doug is doing some work with, I think he's presented on it, hydrogel and other such opportunities to sort of recreate the disc. There are biologics. Again, Doug is involved with one of them. He's been speaking about it for a long time via disc. I'm working hard to get that in my network. We have not been able to yet. There are numerous other biologics, which I'll come back to in 1 second. And then there are also amino acid and peptide type compounds that can be injected. I think many of those are actually going to meet the standard that I want to employ when I'm using a therapy, which is that it's evidence-driven. And working with Lax Munchakanti and ASIP, we published a position statement as well as a fairly comprehensive look at the biologics and what is called regenerative medicine. In my opinion, we're still not there yet. That doesn't mean that practitioners aren't using it appropriately. It's just not what I need to feel comfortable promoting it in my practice. But I think those things are going to change. There are a lot of pre-approval, assuming that the studies work out well, studies that are going on right now. One thing I also should not give short shrift to, it's just, again, not an area that I'm super interested in, but endoscopic discectomy. You mentioned interventional spine, which is why I'm mentioning it. there are people who are really incredibly proficient at that. And some of my friends who are doing it that are proficient are surgeons, meaning there's an embrace by the surgical community. Endoscopic, therefore, could continue to grow. There is a CPT code, Category 1 code, which means it's something you can offer your patients. It's not something, again, I choose to do, but whether any of those make it the decade of the anterior column or just part of a multiple decade-long anterior column run, I would say when I look ahead 1 decade from now, I have no doubt that the people in your position, Jacob, are going to be doing a lot of discal treatments.
Absolutely. And for all the options that you just mentioned, many of which we'll get our hands on at the course, just a lot of ways to approach the disc. And of course, not all disc problems are the same. A herniation, of course, is different than kind of chronic toxic annular tear, different than just persistent discogenic back pain related to Fearman 7 or 8 grade degeneration. And so I'm really looking forward to having more arrows in our quiver. Absolutely. And one of the things you mentioned was, of course, chemonucleolysis. And I find this very interesting because reading back in previous iterations of this technology or this technique is really not novel in any way. And yet, for some reason, it's just failed to catch on, at least in the US, at least so far. And now we have a few potentially very exciting chemonucleolytic agents in the US. And I understand that these are perhaps a bit more used in certain parts of Europe. Now, I'd just like to hear, why do you think that in our country there has been such a slow uptake with chemonucleolysis? And are we starting to see a resurgence in considering its use?
Yes, that's a great question. One word, Chymopapain. So Chymopapain was probably a great treatment that was misused, placed fairly blindly into the disc and really with a crazy escalation takeoff so that there were many, many cases, which put a bad taste in a lot of people's mouth because there were complications that probably should never have occurred. But you took a therapy that could have worked, misused it, and this happens again and again in spine. And that puts, I think, a fear and a bad taste in people's mouth. Actually, your comments reminded me I would be way, way mistaken to not mention, since we're talking about a course that's being hosted by our Italian colleagues, about the opportunity with ozone. Ozone is treated as a medication here in the United States, but in Italy in particular, it's used with tremendous therapeutic benefit in the disc and in other places. And I have no disclosure, but I do think there's opportunities coming in the ozone space. I also wanted to quickly share that there is a school of thought that I learned about on one of these meetings abroad, or in one of these meetings abroad, that has impacted me both academically and clinically as I think about this, which is, could modic 1 and 2 change, well, I guess the whole modic cascade, be a reflection of a chronic smoldering infection? So believe it or not, there are studies going on about using antibiotics to treat this, which 20 years ago, or again, I don't want to date myself, but let's just say when I was in medical school, if we talked about using antibiotics to treat duodenal ulcer, people would have thought you were out of your mind. I think that's an opportunity that's also going to potentially be coming our way in the reasonable future. So let me change that, actually. I don't know whether that'll be borne out, but the idea that it could be borne out is super exciting to me. So I think chemonucleolysis, I'm going to pretend like I said that right the first time, but that word that you said, I think there is truth to the fact that there is some reputational damage that it had related to Chymopapain, but there are so many good things that are coming, and it is important to recognize that after we heard that sticking a needle in the disc results in degeneration, the threshold to stick a needle in the disc went up. Now, whether it really does result in degeneration is a subject that I think we could debate, and I think will be debated. I believe we're going to have an opportunity at the ASIP annual meeting to talk about that. But what I would say is those things probably account for why there's been a failure to generate the interest that we're seeing with some of our European colleagues.
Absolutely. And you mentioned ozone, of course, I think is something very near and dear to especially our Italian spinal interventional radiology colleagues. And so look forward to hopefully getting to experiment with that in the course. And now I would like to talk just a little bit more about something you mentioned earlier, which is the percutaneous discectomy technique. I'm very interested to hear about how you've seen this evolve over time, and how does the percutaneous approach fit, first of all, in the current ecosystem in which we have traditional, minimally invasive surgical, and as you mentioned, even endoscopic discectomies. So where do we fit in currently, and how have the newer iterations improved upon the earlier design that you had some use with?
Yeah, so IDET was developed by the Soul brothers and probably in many ways colors a lot of current people's thinking. IDET was another thing that really took off and then really fell off a cliff. In part because of that, in part, we have a real problem, which is percutaneous discectomy, which is a legitimate evidence-driven treatment. And again, in the case of APLD with tens of thousands of patients, unfortunately is really not reimbursed by insurance. And I would still get referrals for it now. My particular practice is really not well geared for things that are cash pay, in the sense that's just not the situation or the way that I choose to practice. So with percutaneous discectomy referrals, I really tend to try to refer those patients on for something else because the cost of getting it done would be pretty high, and I think there are other good options. Unfortunately, insurance is therefore probably putting a stop to what would otherwise be a good treatment option and a fairly cost-effective treatment option. But I would say that I probably haven't done one in a couple of years. So I think the ecosystem is really not playing out well. But if we expand percutaneous discectomy to percutaneous discal treatments, I do think that there are many people practicing now. You may even be seeing it in Oklahoma City where, well, actually for sure with Viadisc, where you're injecting substances that really have an opportunity to improve discs in ways that we haven't had the opportunity before. Those are percutaneous discal treatments that aren't discectomy, but we'll think of it as regenerative. And I do think we'll see a lot of that in the course because really we'll be talking about image-guided approaches to therapy. So let me step back. I think we'll be seeing that in terms of learning the approach, et cetera. There are only so many companies that are in the space now, but as that opens up, as we talk about the decade ahead, I think we'll be seeing a lot more of that. Once you learn the technique for doing percutaneous approaches to the disc successfully, you really can transpose them between the different substances that you'd want to inject, obviously once you understand the different safety profiles associated with each of those.
Absolutely. And I have to say that disc access is one of my absolute favorite techniques and procedures. It's very satisfying, a lot of fun. Camden's triangle is a very dependable anatomic feature, and I think no one is better equipped to add this to their armamentarium than interventional neuroradiologists and IR doctors. And on that topic, I just want to get your take on where do you think spinal interventional radiologists fit in to kind of the existing ecosystem of spine care? What's the unique value that we provide and that we should be adding?
Well, that's a really great question. My career has been about breaking down boundaries between specialties. I train people who are interested and willing to do the work to become excellent at what they do. I think where spine interventionalists coming from a radiology background have a tremendous advantage is in the interpretation of the images and the execution of treatments safely because of their comfort with image guidance. Let's take an example that I could have used before to answer your question differently. Again, I do have a disclosure in that I'm a consultant for the one company that has an on-label product. You asked about discogenic pain. There was never a discussion of vertebrogenic pain in patients that didn't have a compression fracture until the last few years. And whether we should be talking about vertebrogenic pain, discogenic pain, discovertebral complex, it's not clear to me. What is clear is that the disc, in my opinion, the vertebrae, all of those areas can contribute to pain. And in so doing, if you don't have these treatments available, in the case of vertebrogenic pain or something that's classically partially caused by vertebrogenic pain, so a pain syndrome is partially caused by a vertebrogenic pain, you do another treatment, you're going to fail. Similarly, if you're trying to treat axial back pain that's coming from the disc with maximal surgery, I don't know that you're positioned to succeed. So where do we fit in? I think we fit in the same way. You look at vertebrogenic pain, that's a diagnostic opportunity for radiology to make a big difference by identifying patients, as is occurring with compression fractures, where treatment is optimized, or treatment opportunities are optimized. On the interventional side, which is obviously where you and I sit, it's the appreciation of the importance of the imaging, understanding the imaging, being able to educate our colleagues on the imaging findings, and then using really precise imaging to allow us to do the therapies well. I go back to, why did Chymopapain fail? Chymopapain failed, I think, because it wasn't done using proper image guidance. People were just kind of injecting, and it's hard to think how people didn't appreciate that was going to result in challenges. My belief is over time, maximally invasive will approach minimally invasive, and people who have been pure percutaneous, doing things like epidural steroids, will appreciate that their armamentarium will grow by embracing more therapy. So I see the emergence of the spine interventionalist, and then that'll involve people coming from different specialties. From my point of view, radiology has a ton to contribute, and I don't think radiology threatens other groups, nor should other groups feel threatened as we work together to advance therapy in, let's face it, tens of millions of patients in the United States.
Absolutely. Very, very arcane and esoteric conditions such as chronic low back pain, of course. Not a dearth of patient population, and extremely well said, Dr. Hirsch. I couldn't agree anymore. I think it's a great time to be an interventional radiologist being involved in this area. And the correct treatment, as you alluded to with the saga of Chymopapain, correct treatment is predicated on accurate diagnosis, which of course it depends on very good imaging interpretation. And of course, the ESNR course will have an imaging component and will also be closely linked with the International Weight-Bearing Imaging Society, which will discuss some of the next level imaging techniques that will certainly see become more prevalent in years to come.
Can I say something about that, actually?
Absolutely.
So I'm so glad you brought that up, because I never would have remembered to. When one of the things that I've been blown away by, there's an Italian company called Saote, again, no disclosure there, that makes a standing weight-bearing MRI. And in the United States, it's actually, at least in a big academic center like mine, where you have certificates of need, it's very difficult to justify getting one of those machines. The problem is when you start seeing the images that Dr. Manfrey will show at this meeting, you wonder how we're working just based on supine imaging alone, because
Absolutely.
the dynamic range of what you can see is just unbelievable. Another quick pitch, Luigi Manfrey, again, the person who really is the dreamer behind making this course a reality, does things using cone beam CT, image guidance that really is next level. And guys like me, and probably you, Jacob, think of that as, why complicate things? Well, until you see Luigi do it and you realize, wow, it's really pretty special what he's able to do with that kind of image guidance. So whether you're coming from the United States or somewhere in Europe, or really from anywhere around the world, there's so much that one can learn. The instructors learn from each other. And as a result, now the instructors even participate as students, being able to see what others can teach. I specifically boycott the Beal sessions, but that's personal. That's animus. That's not based on knowledge. And you be sure to tell him that I said that, Jacob.
Oh, I will. He's listening right now behind the door. No.
Like I said, I'm brave when we're separated by a couple of thousand miles, but I'll be much more mild when we're in person. And I'll say, I don't know what Jacob was talking about. I never said anything like that.
Well, for all the reasons you said, we have a lot to look forward to at this course. It's going to be an excellent international cross-pollination of approaches and techniques and devices. I personally am looking forward to getting to see some of the European devices that we're still waiting for on American shores. I think that there's just so much that's going to be very fun about the course. And so as we conclude our discussion, Dr. Hirsch, what are you most excited about in the hands-on course?
Phil, I actually think, because I'm getting a new machine in June, it's that cone beam CT stuff. For me, and I think guys my age, we always talk about the opportunity that cone beam CT would provide, and then just go back to X-ray because we're so accustomed to it. It's so straightforward for us. In the last meeting, when I saw not just in lecture form, but practically, Luigi takes some of those next generation devices that we don't have and do them under cone beam CT guidance. It really opened my eyes. And the room that I'm using is being replaced with a 2024 vintage room. I won't tell you what year the prior room was from. It had the opportunity to cone beam CT, but not practically because of how long it would take to process. But if you could process in near real time, I'm not saying I'm there yet, but I'm really open-minded to thinking about changing my practice this way. And it would be important for me because every time I've had something that has aided my image guidance, like quasi-robotics and or things that reconstruct a CT scan, in the end, I don't do them because I just go back to, oh, it's so easy for me to do it in this more traditional way. I really think there's something that might be there now that I have a machine or will have a machine that can reprocess like that. There's no one better to learn it from than Luigi Manfrey. So I'll be lined up alongside you, Jacob, to see whether or not that's transferable back to the United States. What are you most excited about?
I have to say I'm right there with you. I'm really looking forward to using all the modalities. Ultrasound-guided spinal procedures, not something I've had a lot of experience with, so definitely looking forward to that. CT, cone beam CT, fluoro, and perhaps some even MR-guided procedures. And, of course, all this in the world-class facilities at the Oncologic Institute of the Mediterranean, Dr. Manfrey's home stopping ground. So I am very excited about this coming up in April. Of course, I'm sure the weather in Catania will be absolutely brutal, absolutely borderline.
Insufferable.
Insufferable.
The one thing that I think it's fair to say is if you were to go to the next room and ask Dr. Beal what he's looking forward to most, it's hearing pedantic lectures from folks from Boston. And that may be about spine, but it also may be about the Patriots, the Celtics, whatever other important topic that comes to mind. I'm really appreciative of your hosting this. I am excited to see you, Jacob, and the many attendees. These courses are basically always sold out. I think once Luigi put them together, the reputation went pretty far and wide. And like I said, we get people from all over the world. We have the added component of the Weight-Bearing Society, which is only going to bring more interesting stuff. As they said before I was born, be there or be square. And I don't want to be square.
I do not want to be square, and so I'll look forward to seeing you in April at the ESNR hands-on course. And to our listeners, get on the registration quick because the spots are filling up, and we look forward to seeing many of you there. And Dr. Hirsch, thank you so much for your time. I thoroughly enjoyed this conversation, and I look forward to traversing Camden's Triangle with you very soon.
Well, that's wonderful. Sounds fun. Well, I guess I should have said be there or be triangle, but that just doesn't work as well.
We'll work on it. We'll workshop it.
Take care. It was wonderful, Jacob. Be well.
Take care. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable MSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Junwood Kennebrew.
Thanks again, and see you next time.